Dr. Kathleen. I first met her at Purdue University. She was in her final year of the PhD program in nutrition science when I first started as a first PhD student. She graduated, left for her postdoc, then came back as an assistant professor. And I was finishing on then. I was my final year when she came back. So one thing that really, struck me with her is that she always has this very genuine smile without effort. And as a new graduate student who was getting used to a new environment, it made a whole lot of difference to me. Stopping by the hallway and checking and saying, "How are you?" It was really great. So it's definitely an honor to be able to introduce her. So she's currently an associate professor of nutrition in the Department of Food Science and Nutrition at the University of Minnesota, Twin Cities. She also holds an adjunct faculty appointment with the Department of Medicine within the Division of Nephrology at Indiana University School of Medicine. Prior to University of Minnesota, like I said, she was an assistant professor in the Department of Nutrition Science and the director of the didactic program in dietetics at Purdue University from 2013 to 2020. She holds a master's in kinesiology and a BS in dietetics from the University of North Dakota in Grand Forks. That's her hometown. And she's been a registered dietitian since 2005. She earned her PhD in nutrition from Purdue University under the mentorship of distinguished Professor Connie Weaver. Those of you that know her, she's well known for research in mineral absorption and metabolism within subgroups, and also has investigated subgroup differences. And her work contributed to certain nutrient requirements for adolescents in North America. Dr. Hill Gallant completed 3 years of postdoctoral training in bone and mineral research at IU School of Medicine, and she was mentored by Professor Emeritus of Medicine, Monroe Peacock, who is also a giant in the field. She currently leads a clinical and translational research program focused on mineral metabolism in chronic kidney disease, with emphasis on phosphorus, calcium, and magnesium. Dr. Hill Gallant is currently funded by the Minnesota Department of Agriculture and also by the Agency of Healthcare Research and Quality. She is a previous NIH, NIDDK, K01 awardee, and recently completed an NIH R03 grant. In my earlier discussion with her today, I learned that her R01 application got ranked. She's on the 5th percentile, so fingers crossed she gets funded. Dr. Hill Gallant is a fellow of the National Kidney Foundation since 2021, and also a fellow of the Academy of Nutrition 2019. She won the Rising Star Award for the American Society for Bone and Mineral Research 2017 to 21. She has close to 60 peer-reviewed publications in reputable journals and has mentored several undergraduate, graduate, and a couple of postdoctoral fellows. She has several book chapters to her credit and has been invited to numerous prestigious platforms to give presentations such as today's. Please help me welcome
Thank you. That was such a nice introduction. It was very heartwarming. That was so fun having both of those paths cross at Purdue with you. So I have really been enjoying my day here. Thank you so much for inviting me to come and talk to your department. I feel like every single conversation I've had today has, like, I haven't wanted it to stop. So that's just really great. Thank you for showing me a really great visit and your beautiful facilities and all of the wonderful work that you're doing. So today I will talk a little bit about the research that we do in phosphorus and calcium metabolic balance studies in CKD patients, combined with intestinal absorption studies where we use isotopic tracers, as well as our animal complementary animal studies. Oh, I had this working, and then let's see here. Oh boy, if it's just the advance, it's not a big deal. So first I'll give you a little bit of a background on chronic kidney disease, and specifically chronic kidney disease mineral bone disorder, or CKD-MBD, which is a little bit of a niche topic. However, it's very prevalent in patients with CKD. We'll talk specifically about the role of phosphorus in CKD-MBD as more of the background, and then shift into some of what I think are some of the key findings that we've had in recent years with phosphorus and calcium from our metabolic balance and absorption studies, both in rats as well as in human studies. So chronic kidney disease, for those of you who aren't familiar with the disease, It's defined as the presence of kidney damage or the declining kidney function for at least 3 months, and it's a progressive disease. This was a cartoon that was found by one of my previous PhD students several years ago, and we've been kind of using it ever since because I think it really conveys how this disease progresses to the point of requiring renal replacement therapy, so dialysis or a transplantation towards end-stage renal disease. For the most part, our group has been focused on the moderate CKD, where there's reduced kidney function. It's about 75% reduced or so. And this is often where patients really need to be managing things like diabetes and their hypertension, possibly starting to control their dietary phosphorus intake, et cetera, to manage their comorbidities and prevent disease progression, hopefully. And so this is not up to the point of needing dialysis. So they still have quite a bit of kidney function left, but it's really important where they are starting to do some of those lifestyle diet changes in order to prevent or aim to prevent disease progression. I remember I need to point at this. I always do that with these pointers. I point at the screen. That's not where the sensor is. So one of the things that whenever I go and talk to audiences who aren't CKD particular audiences is try to impress upon people or get them thinking a little bit more about CKD actually as a major public health problem. So it affects about 13–14% of the world population. It's 37 million Americans that are estimated to have CKD. It's about 1 in 7 adults, and about 1 in 3 American adults are at risk for CKD. And this is due to the high prevalence of the 2 main causes of chronic kidney disease, which are diabetes and hypertension. And there are also racial and ethnic disparities in CKD, both in terms of risk of developing CKD as well as progression. And so this, for those of you who don't really necessarily have CKD on your radar as a public health problem, I think when we really think about these numbers, it seems like that's a lot and I should know more people who have this. But the reality is that the awareness of CKD is very, very low. So about 90% of those who meet the diagnosis criteria for CKD aren't diagnosed and aren't aware that they have it. And that is even a large portion of people who are in that very, very late stage of CKD up to the point of really being close to needing dialysis, where still about half of them are not diagnosed yet. So there are quite a bit of initiatives to screen and identify these patients earlier on so that they can focus on preventative measures to prevent CKD progression. But that is one of these things, right, where it's like if we connect this with, I think, a general appreciation for the fact that diabetes and hypertension are major public health issues, and that CKD is a consequence of these other diseases. So I mentioned that my kind of niche area is in this realm of CKD mineral and bone disorder, or CKD MBD. This is actually quite prevalent. It's not a small fraction of the people with CKD. As people get into moderate and progressing into late stage CKD, it's very, very common that these patients are displaying some or a combination, a few of these features, and it's very heterogeneous in these patients. So CKD MBD is really this trifecta of characteristics. So it's a systemic disorder. It's from CKD and it's affecting bone and mineral metabolism. And it's characterized by having these lab abnormalities, particularly phosphorus and calcium metabolism lab abnormalities, where the calcium and phosphorus regulating hormones become abnormal, and eventually serum phosphorus and calcium as well. And then clinically manifesting in abnormalities in bone. And this is also very heterogeneous, various abnormalities in bone turnover. It can be very low, it can be very high. They can have mineralization defects. They can have low bone mass. In kids with CKD, it can impair linear growth, and ultimately all affecting bone strength, as well as the other main clinical concern is vascular calcification. And these all then lead to an increased risk for cardiovascular disease, fracture, and increased mortality related to these. So this figure was actually published by one of my current mentors, Sharon Moe, and my colleague, Thomas Nicholas. Sharon is the division chief of nephrology at IU School of Medicine. They published this showing the increased hip fracture incidence as CKD progresses. So there's higher incidence with worsening CKD. So on the black line here, that is the general population. You can see, as you're probably almost aware, that we have very low incidence of hip fracture in these, make sure I don't push the wrong button, in these earlier decades of life, and then hip fracture incidence begins to increase with older age. This is elevated at all levels of CKD. So even in just moderate stage CKD, which is stage 3A and B here, it's quite higher than the general population, and it just gets more and more pronounced as folks progress into the disease. I'm going to be doing that all day here. And this is just another piece of data to just highlight how this cardiovascular mortality also increases with CKD. In this case, we're looking at dialysis population across different ages and their cardiovascular mortality rates compared to the general population across different ages. And you can see that it is pretty high, even in the youngest ages here. And if we look at the 25 to 34-year-olds in the dialysis population, they have about the same cardiovascular mortality rates as the 75 to 84-year-olds in the general population. So this is very pronounced, and most people with CKD will, mortality is from cardiovascular events rather than actual kidney failure. So cardiovascular disease is a very, very important concern in chronic kidney disease. So going back to this model of CKD-MBD, for some of you, you may have heard of, just put as an aside, renal osteodystrophy. That is the old term, but it's also a piece of this. So renal osteodystrophy is still used as a term referring to the bone abnormalities. So this term replaced renal osteodystrophy as an umbrella term, and then now renal osteodystrophy is just referred to as the bone abnormalities. But really, phosphorus is considered to be this kind of main culprit as far as setting the events in motion that lead to these abnormalities and greater fracture risk and vascular calcifications and cardiovascular mortality. So really at phosphorus regulation dysfunction. And when we think about phosphorus, we can take a moment to think about what is its role. It's a nutrient, right? It is a essential mineral, but it's very, very common in our food supply. It is just highly prevalent. It's kind of everywhere, particularly in high protein foods. So it's very associated with protein naturally. And excess dietary phosphorus intake is common across most age groups. The only age/sex group here is the kind of preteen teenagers who are maybe kind of meeting their RDA as a population, but by and large, we are far surpassing our needs for phosphorus intake. So for adults over the age of 19, it's only 700 milligrams per day, and there's some estimates that kind of on average about 1,400 milligrams per day is consumed by an average American adult. And we also have phosphorus. So we have phosphorus coming from natural sources, say like meat, these protein foods, and also plant proteins. So nuts are a very, very high source of phosphorus. Phytate is a storage form that the phosphorus is present in the plant sources. We have a lot of phosphorus coming from grains. And then our kind of quintessential bad guy, I guess, for the phosphorus world and phosphate additives is cola with phosphoric acid, so considered to be highly bioaccessible, although just the amount of milligrams phosphorus wise is actually not one of the higher ones, but we have a lot of phosphates added in our food supply as well too. So phosphate additives provide a lot of functions in foods, emulsifiers and preservatives, preservatives, etc., but it's contributing a lot to our phosphate burden. So this is considered to be a problem, and there is a lot of building epidemiological evidence that I'm just highlighting a couple statements here, but there are very, very consistent relationships between higher serum phosphorus and both all-cause mortality and cardiovascular mortality in a lot of different populations. So this has been shown in general population, in a cardiovascular disease population, in CKD populations, in dialysis populations. And so one of those, criteria for establishing causation, right, is consistency. So we have a lot of data in a lot of consistent studies in the literature showing this relationship. And what is also notable is that higher serum phosphorus, even within the normal range in a general population, is related to greater mortality. So there's a lot of evidence of this relationship, at least. There is much less available relating dietary phosphorus intake and these mortality outcomes, but there are a couple studies out there that are also showing this. And these relationships have some biological plausibility for what is going on there. So phosphorus has been shown to induce vascular smooth muscle cells to transdifferentiate into osteoblastic-like cells that can actually start to lay down collagen matrix and cause calcifications, directly promoting these vascular calcifications as well. And through actions of the phosphorus regulating hormone FGF23, phosphorus is implicated as well in left ventricular hypertrophy. So these studies show that FGF23 promotes LVH. So there's a lot of evidence for these potential adverse relationships of serum phosphorus or excess phosphorus and these outcomes. So if we want to take a look at phosphorus homeostasis and how it's regulated, just as a review, we have a multi-tissue axis of bone, intestine, kidney, and parathyroid glands that are participating in this, and three main known phosphorus regulating hormones. So FGF23 and PTH are mainly phosphaturic hormones promoting phosphorus excretion in the presence of a high serum phosphorus, and 1,25-dihydroxyvitamin D, which classic role would be to increase phosphorus absorption from the intestine. However, when we actually look at kind of the whole body physiology, there are studies that have shown that the kidneys like really efficiently regulate phosphate in health. So if you have healthy functioning kidneys, there have been studies where phosphate's just been infused and it's completely excreted in the urine. And when you have that kidney, they can do all of this work. So what's really not well known is what happens when the kidney is not able to do that job anymore. We have the intestine that becomes the place where we look to for regulation. But it's really not well understood how that regulation occurs and really if it is adequate in any sort of compensation for reduced kidney function. So controlling phosphate in CKD is really central to CKD management, or say CKD MBD management, but this is very, very common. And really the methods of controlling phosphorus in CKD are very focused on intestinal absorption. So there's dialysis, right? But you have to be far enough along in your kidney disease to require dialysis. And dialysis also does not fully compensate. And we have then these kind of two main therapies that have been the go-to approach for a very long time is dietary phosphorus restriction and use of phosphate binders as medications, and there's different types. So we'll talk a little bit about that. Yep. Sorry, go ahead. Yep.
From the last slide,
Yeah.
I'm just trying to
Oh, sorry.
the direction.
Oh, yeah.
Does kidney function worsen and then phosphorus goes up? there's phosphorus up in states that cause kidney disease.
So first the kidney function happens, or the kidney function decline happens. There are upstream effects that have been started to be characterized. So there's FGF23 is actually one of the first. I have this slide a little bit later on that'll show some of this. But FGF23 is actually the first abnormality that is kind of detectable. It's not measured clinically, but is this kind of like first responder in terms of we need to start ramping up how much phosphorus is being excreted, like kind of per functioning nephron in the kidney. And there's even some upstream effects of that as well too, like clotho deficiency. So clotho is a co-receptor for FGF23, and there's also clotho deficiency. So it's the kidney dysfunction first, but then when serum phosphorus actually turns into hyperphosphatemia, that is also kind of nephrotoxic.
So
Yep.
all this diabetes and other effects that affect the kidneys.
Yeah. Yes.
And then-
Yep. So it's, to my knowledge, it's not known. So it's like, if you have, or that there's not, I don't know of evidence that, if you have healthy functioning kidneys and you, well, I mean, there was the one in the news, right? Recently, the woman, it was like last year or something, like really, really drank a lot of cola or something like that. And actually, like went into some sort of acute thing. But that's like a very extreme scenario. So yeah.
The diet can't cause kidney. The diet makes this worse.
Diet makes it worse. Yeah.
Okay.
So there's some hypothesis in terms of possible mechanisms, but it doesn't really bear out. There's sometimes like, oh, if you eat too much protein, you're going to cause kidney disease. If you eat too much, like that not a lot of evidence that those things are happening. So maybe this, very extreme examples of, I don't know how many gallons of cola was drank by this person. Yeah, good question. So intestinal phosphorus absorption, some of the things that we do know, and there's a lot of question marks going on in here that maybe aren't even so apparent initially. So we have a transcellular saturable pathway of phosphorus absorption, as well as a paracellular, considered unsaturable, gradient dependent, concentration gradient dependent pathway of phosphorus absorption. And if we look at if we just kind of zoom in on the intestinal epithelial cell here, this is depicting both of these mechanisms here. We have the main known phosphate transporter, sodium phosphate cotransporter 2B. There are other minor ones considered to not participate very much, PIT1 and PIT2. And then there's also some research that we might not even know if there's other important transporters there. So we think it's this one. It's based a lot on mouse studies, but there's some evidence that there may actually be other yet to be identified transporters. But this is considered to be the known one that is mostly responsible for the active transport. Then we have paracellular transport depicted here, and NHE3 is shown here. This NHE3 exchanger, sodium and hydrogen exchanger 3 actually has a new drug, tenapanor, that targets this NHE3, which tenapanor blocks NHE3, and this buildup of protons by blocking NHE3 changes the pH, right, in the intestinal epithelial cell, and actually has an effect of selectively closing tight junctions to phosphates. So calcium still gets absorbed just as well and all of that, but it's newly approved by the FDA to actually as really the first approved actual intestinal phosphorus absorption inhibitor, and not just a phosphorus binder. And phos binders, these are depicted here, right? So this medication that would be used, you have phosphate floating around in the intestinal lumen, and the idea that these various phosphate binders bind phosphate and just prevent it from being absorbed. So also want to just note here, there's nothing identified yet over here. How does the phosphate get out of the cell? How does it get across the cell? There's some hypotheses, but there's if you actually compare this to, you know, the model for, say, calcium and stuff, like we really don't know who, like, what the players are in the phosphorus absorption model. So active and transcellular absorption has been shown to increase with a low phosphorus diet and with higher 125D, and then conversely with lower decreasing with lower 125D. And then some other compounds like nicotinamide and nicotinic acid have shown some effect on decreasing transcellular absorption. And there are some of these NaPi2b and PIT inhibitors that are in development, but so far they haven't translated to humans well. They've shown some really cool efficacy in rats and just not translated. Also some more evidence that there's other things going on with the transport mechanisms in humans. So, and if we look at passive and paracellular, it's really related to the intestinal lumen, the load there, as it's just this linear relationship. So increasing with higher luminal load, so a high phosphate diet, and decreasing if you lower that load, and that can be accomplished either low phosphorus diet or phosphate binders, and then now also directly with inhibition of this NHE3 inhibitor. So we really, though, have a lot of limitations and knowledge gaps. So there are some things like there are transport proteins and all of this that, you know, there's huge black boxes there. That's not the area that I work in, but there are a lot of aspects of phosphorus absorption that we just don't know how they function yet. But thinking about just more fundamentally even, there's really limited research in general that is focused on intestinal phosphorus absorption in comparison to phosphate handling in the kidney. And there's really been really few in vivo intestinal phosphorus absorption studies in either animals or humans. So most studies have been done in rats, but then using ex vivo in vitro methods to actually measure phosphate uptake, et cetera, from brush border membrane vesicles and these sorts of things. So we also don't know the effect of CKD progression on intestinal phosphorus absorption. So there's a lot of rationale that can be kind of lined up, like, okay, they're going to decrease their 125D, that's seen in CKD, that should have an effect, but does it? We don't really know. And so there really are inadequate therapies due to these and other limitations to actually manage abnormal phosphorus homeostasis in CKD-MBD. So it's really dialysis, phosphate binders, and dietary phosphorus restriction, but that is not enough in people who are on dialysis and have hyperphosphatemia. It's not sufficient. It's still really hard to manage. So our approach has been that we are trying to fill some of these gaps by using in vivo or in situ models in rats for absorption studies, as well as studying phosphorus absorption clinically in humans. And just conceptually, right? So in vitro and ex vivo methods, these are really, really important. And this is where we have most of our knowledge from. They can be very tightly controlled mechanistic studies. We can learn a lot from them. You have these tightly controlled conditions. You can get site specificity, but you have disruption of a lot of the normal physiological systems, the vasculature, et cetera. It's only a snapshot. And then even though those you can tightly control these conditions, they might not be physiological. And when we look at our in vivo studies or clinical studies, they have much higher translational value with their physiological relevance. You have these whole body systems that are intact, but then they have their own limitations, right? You get less site specificity. There's a lot more confounding going on. You're less able to actually pinpoint specific mechanisms. So really, I mean, what's one better than the other? No, but it needs to be a process. It needs to be not just stopping at, we know these things because we saw it in vitro, but actually saying, can we see it in vivo, right? And actually testing it out. So that's where we have really taken our approach over the last several years. So these are some of our initial research questions that I'll show you a little bit of highlight on that we've learned from some of our rat studies. So these have used in vivo or in situ absorption testing methods in rat models. So you can see they're kind of going back to like, wait, I already told you we know these things. We already told you we know low phosphorus intake will increase phosphorus absorption. But most of that is based on these in vitro studies, right? So this knowledge is based on not having translated it yet to see if it happens in vivo or it happens as cleanly or in all these conditions. So really, what are the effects of dietary phosphorus intake on intestinal phosphorus absorption? What is the effect of CKD progression? And what is the relationship between 125 dihydroxy vitamin D and intestinal phosphorus absorption? So again, I have already mentioned that we know dietary phosphorus intake and 125D are the things, the two things that we know influence phosphorus absorption. But again, based on in vitro studies largely. So this first study that I'll highlight a couple results from, this was looking at the effects of dietary phosphorus intake on intestinal phosphorus absorption in healthy rats. And the premise here is what I've mentioned, that dietary phosphorus is considered one of these major factors. And it's considered that this is like kind of established knowledge, right? But we don't have much evidence in the literature of whether this is happening in vivo. And so in this one, we're just looking at healthy rats. And our aim was to determine effects of phosphorus intake on phosphorus absorption efficiency. And our hypothesis was that we would find what we expect. We would find what has been found in vitro, that a low phosphorus diet should increase 125 dihydroxy vitamin D. It should increase the expression of the main known phosphorus transporter, NaPi2b, and it should increase intestinal phosphorus absorption efficiency. So we did, this isn't an age study, so we did these 3 different ages. It's a little bit of a detractor, but I didn't want to not accurately represent my, the design of my study. It was a 3x3. We did these 3 different ages that actually correspond to the ages of rats in a kidney model that we were using in the next study. Okay, so don't be too fooled by these ages. We're not really studying aging here. We were looking at these different ages in a healthy rat that were then moving forward into a different model. But it was a 3x3 factorial design, and we also had 3 different phosphorus levels in these rats. So a 0.1% low phosphorus diet, a 0.6% normal, and a 1.2% high. So for reference, the rat requirement is a 0.3%. So the normal you can kind of consider as, I like to think of that translationally as like, well, that's kind of an average American diet of having twice as much phosphorus as you need. And then the low is low, but it's not totally deficient. So there are some animal studies, some rat studies that have like a 0.02%, which is basically phosphate free. So this is low, but still physiological. And this was, we had a 2-week feeding study, and then it ended with a 30-minute jejunal ligated loop absorption test. The jejunum has been identified as the site of the highest amount of active phosphorus absorption in rats. And so in this 30-minute study, the rats were alive. This was a terminal procedure. They were under anesthesia, and they were, we identified the segment of the jejunum of interest. We tied off each end with these ligatures and injected a phosphate containing solution of a low phosphate concentration that would be at the level where active absorption should be predominant. And we use this P33 radio tracer. So over these 30 minutes, we took blood samples, and then at the end too, we also excised the loop and analyzed that for the remainder of the phosphorus, the P33 within that loop. So, we actually found that phosphorus absorption efficiency was not affected by dietary phosphorus level. So this was like this first, like, oh, it's not holding up in vivo. So you can see our 10-week-old rats, they have higher phosphate absorption efficiency. They are younger, they are growing at a more rapid rate. So that's kind of the explanation there. But the low, normal, high phosphorus did not affect this phosphate absorption efficiency when we tested for that effect. And it actually didn't raise 125D, which was another contradictory finding compared to the previous work of others in vitro. And we also found that NAPI2B expression wasn't affected by the low phosphorus diet. So the main hypothesis was that at least the low phosphorus diet would increase phosphorus absorption efficiency related to an increase in 125D and an increase in NAPI2B expression. Kind of none of those things happened. So that was our first kind of surprise finding. Then in the next study, we moved into a CKD model. So we are looking at now the effect of CKD progression on phosphorus absorption efficiency. And here the premise is that phosphorus absorption really is that target of a lot of our therapies for trying to manage phosphorus in CKD, because the kidney is starting to not work as well, and we're focusing on the intestine. But it's really unclear how does CKD progression itself, the disease itself, even affect phosphorus absorption efficiency. So we look at this progressive CKD rat model. And again, we are going to hypothesize what it should do based on the in vitro data and what we know about the physiology of reduced 125D. So we're hypothesizing that moderate and late stage CKD are going to result in this reduced, a progressively reduced in phosphorus absorption efficiency, and that's going to be accompanied by or explained by a reduced 125D in these rats. And so just to, this is my little sequence thing that I was alluding to earlier with the question, is that as CKD progresses, in the earlier stages, the first kind of signal of abnormal phosphorus homeostasis is an elevation in FGF23, which has the main role of being a phosphaturic hormone, decreasing the amount of phosphate reabsorption in the kidneys and increasing it in the urine. FGF23 actually has actively suppresses 125D. So kind of the old model of why is 125D conversion declining in kidney disease is that it's a kidney enzyme, the 1-alpha hydroxylase enzyme, and that you must be losing that function. And so while some of that might be happening, it's actually shown that if it's this elevation in FGF23, it's actually an active suppression of the 1-alpha hydroxylase enzyme. So then you get this low 125D, PTH starts going up as the inhibition of 125D is kind of released from it. And so these are all working to try to keep serum phosphate normal until those compensation mechanisms just can't keep up anymore, and then serum phosphate begins to go up. But if there's an explanation for what's going on here, what is the body trying to do to be FGF23 and PTH are increasing to get more out in the urine, and 125D is going down, and one would hope that it has this compensatory effect of decreasing intestinal phosphorus absorption. Don't get as much in the body to have to deal with. So that's the premise there. So this rat has been characterized and phenotyped as a progressive model of actually the whole phenotype of CKD-MBD. You can feed it a casein-based diet that starts to time and kind of standardize when it is progressing through its disease states. And the 20-week and 30-week-old rats are similar in terms of their kidney function to a kind of stage 3 moderate CKD or a late stage 4 CKD. And again, we did this ligated loop absorption test in these rats. This just has one dietary phosphorus level, so we're just looking at the effects of the kidney disease. So phosphorus absorption efficiency was actually higher in the CKD rats. So this is opposite of what we would expect, right? We think that the 125D is going down, that the absorption efficiency should go lower, and it's actually higher at both ages in the CKD rats. So it's a little bit of a conundrum there, but it was despite lower 125D in these rats at both ages. And there was no response or effect of the disease progression seen in the NAPI2B gene expression with the CKD progression in the place we were looking at. So that would correspond. However, we don't have absorption tests in the this is just in jejunum. So we did see a lower amount of this NaPi2b gene expression. That's not protein expression. There's challenges with measuring so is a limitation here of when we're looking at the NaPi2b transporter here. So maybe in the duodenum we would have seen something, but we don't have those data. So this really stands out as strange, except for we really followed these methods of this one other group who had been who had previously investigated the effects of a different type of kidney disease model, this 5/6 nephrectomy, versus sham operated rats a few years earlier. And we modeled our methods to follow what they were doing. So this in vivo intestinal ligated loop method, same phosphate concentration, et cetera. And they found no difference with CKD in the jejunum. So where, as we said, we had found that it was actually higher in the CKD rats, but and again, not significantly different, but it's not lower, and it's like actually kind of higher. So, you know, given that there's only 2 of them, maybe try to like read into it. It's like, well, it's at least not contradictory to what we found. And then we also see that in their study, they found this lack of difference, despite the fact that the 5/6 nephrectomized rats had lower 125D compared to the sham rats. And then they had another part of their study where they gave a low phosphorus diet, which increased the 125D. And this also did not cause a significant difference in the phosphorus absorption in these rats. So these studies are showing that there is maybe a disconnect. There's not a lot of them compared to the in vitro studies that have been done. So there's certainly a weight of evidence on the in vitro studies, but it really requires further investigation. So we have then shown, and in agreement with like kind of the one other group that's been doing some of these, that there is conflicting effects of dietary phosphorus restriction, where in vivo it doesn't seem to be having an effect to increase phosphorus absorption, that CKD progression does not seem to lower intestinal phosphorus absorption, even though 125D is lower, and that relationship between 125D and intestinal phosphorus absorption, which is kind of the classic action we think 125D has related to phosphorus homeostasis, isn't observed in our studies. What time do I have until? I have 5 minutes. Oh my gosh. Okay.
15 until.
Oh, okay. All right. Okay. 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 Yes, that's good. Okay. So good. Okay. Yeah, I forgot when we started. Okay, it's good. So let me tell you a little bit about our human studies. So I think just in the interest of time, just highlight that these next 2 slides, just the concept that whole body phosphorus balance in the context that I use it is not the same as homeostasis, that is really dependent on, especially for calcium, maintaining serum ionized calcium within a normal range. And that whole body balance can be much different than what is observed in the blood. And that it's really this, can be considered what this whole body retention is. So that's true for both phosphorus and for calcium. And then particularly with calcium, it's important to know that, I think this is a good example of where, like in CKD, a positive calcium balance may put people at risk for, maybe vascular calcification, maybe that it's bone formation, those sorts of things, but it's not necessarily hypercalcemia, not the same. And similarly, you can have bone mineral density loss, right? You can have people with osteoporosis who are losing bone. They can have normal serum calcium. In fact, they usually do, right? Because these are not the same concepts. So that is really an important point, where serum calcium and phosphorus are not reflective of whole body balance. And I'll show you some of the data that we show that on. So with our metabolic balance studies, we have these advantages of doing metabolic balance studies, where you, for one thing, a controlled dietary intake, This is really helpful when you want to know the effects of diet. You can't do it for very long, but you know what that exposure is. And you're getting this complete urine and fecal collections as well. So you can really look at this whole body physiology. When you have the full balance, you can look at these different components. You can look at net absorption versus fecal excretion versus urine excretion. And when you combine them with isotopic tracers, you can actually get fractional absorption that can be modeled to from the modeling, and also differentiate between bone turnover. So of course, the disadvantages is that limits to sample size, limits to the study duration, et cetera. So calcium is commonly used as a phosphate binder, but there are pros and cons to its use. It can be it's effective as a phosphate binder. It can lower serum phosphorus. It could lower PTH, could prevent bone loss, but it also can promote potentially soft tissue calcification. It could exacerbate hypercalcemia, and it could oversuppress PTH. So what to do with calcium in CKD patients is kind of controversial, but it's also like really one of the cheaper phosphate binders. So it's very commonly used. And there is with that, there is also a question of, do the CKD patients even absorb calcium very well? So we did a calcium and phosphorus balance study in CKD patients that was a crossover study that included 2 weeks of balance on both receiving an additional 1,500 milligrams of elemental calcium per day versus placebo, and investigated the effects on whole body calcium balance as well as its components. And what we found was that calcium carbonate in the form of carbonate given with meals, so that's how a phosphate binder is given, actually it increased phosphorus balance, but it had really no effect on increased calcium balance, excuse me, with no effect on phosphorus balance. And so over here, the diet levels here are just for reference, those were controlled. But what's really notable is that urine calcium was very, very low, and it was not changed when we gave them an extra 1,500 milligrams of calcium per day. And this is resulting then in this higher calcium balance. And phosphorus balance, there was this little signal in the urine, which is what you would expect from a phosphate binder, but it wasn't really enough to find an overall effect on phosphorus balance. And serum phosphorus and calcium levels were completely not affected because we shouldn't expect them to be. They're controlled by different mechanisms, and they're not the same as balance. But this is evidence that you can have, particularly that you can have very high calcium balance and not affect serum calcium whatsoever. So our calcium kinetics data, well, let me actually, so the thing about the low urine calcium is like, this is what is observed, you know, and this is what has been observed, that these patients, they're CKD stage 3, they're producing urine. It's not that they're just like not producing urine. They're also excreting plenty of phosphate. Urine calcium is particularly and like uniquely just low in these patients. So the thought is they must not be absorbing their calcium. And so then if we give them calcium binders, it binds phosphorus, and it's just fine because they're not absorbing their calcium. It's not putting them at any risk for, say, vascular calcifications from, you know, too much calcium. However, we did our kinetic studies. Also in this, we gave an oral and IV dose of the radioisotope calcium-45. We have a method where we stagger them apart in a way that we can differentiate them with using the same isotope. I can tell you more about it if you're interested. But from this, we found that fractional calcium absorption and then calculating total calcium absorption in these patients was really responded with the higher calcium in their diet. So the idea that there's just low calcium because they didn't absorb any was really refuted by our data. So the key findings there were that really that calcium absorption is like efficiently maintained in CKD. These serum levels don't reflect whole body balance. Urine calcium is very low, and does not change when you give them a bunch of calcium. And then we have seen this over and over again in our subsequent studies. So this kind of highlights how without these balance and kinetics data, and only relying on what is usually available, maybe if looking at this signal of low urine calcium to give you an idea of what might be happening at a whole body level, it would be reasonable to make the erroneous conclusion that absorption isn't happening. But we're able to see with these methods that that wasn't the case. So I was able to reveal that. Oops. I'm actually getting pretty close to, let's see what I have left. So I leave some time for some questions. So this is just highlighting that calcium balance is kind of tricky in CKD. They're at risk for both vascular calcification and bone loss and bone disease. So getting calcium right is important. And so there is a need to have adequate calcium, and our balance data, and then the data from one other study by David Spiegel, we wrote a little review on it a couple years ago, really started to point towards about 800 to 1,000 milligrams per day of calcium to kind of get people in, usually in a calcium kind of neutral balance. And the idea that calcium is getting absorbed, but it's not getting excreted, so it means it's getting retained, is actually shown then from some clinical trial data looking at the effects of phosphate binders on coronary artery calcification. In their primary analysis, they found that any phosphate binder had higher coronary artery calcification. So this was the primary analysis, but when they broke it down by the different types of binders that patients were on versus placebo, so lanthanum and sevelamer, non-calcium-based binders, versus calcium, it was really calcium that, for one thing, had a huge amount of variation. So signaling that, you know, these patients are in like totally different calcium status, right? But that was the driving factor in their overall conclusion here, or the overall finding. All right, so we also, let me just show you. We did a follow-up study from these data that we had all of this good timed urine collections, et cetera, to investigate how reflective is urine phosphorus of phosphorus absorption. So we were looking at, okay, calcium is not showing us a lot about calcium absorption in these patients. Urine phosphorus is often cited as like a gold standard of phosphorus absorption, but how accurate is that? So we looked at that from the same study in a separate paper. And these different colored lines, these are the different people in the study across all of these different 13 days of complete collections that we had. And they were inpatient, they had timed urine collections with the CRC nurses, and the intakes tightly controlled, and had urine phosphorus that had a lot of variation within the people and then also between them as well. We then looked to see if that urine phosphorus was related to net phosphorus absorption, which we also had from this study. And a little bit of, I mean, there's 8 people here, right? So a little tenuous to have to look at these correlations with a small sample size, but we didn't see a relationship with net absorption. However, we did see a relationship with retention. So as urine phosphorus was increasing, that was actually related to just less retention rather than they were absorbing more. So it's kind of the opposite of what we saw for calcium. And this is really significant because to translate it to, if you only had urine phosphorus, which is what people would usually have, if these are 2 subjects in the study, one with high urine calcium and low urine calcium, it would be if you had no knowledge of where this came from, you would think this person has a higher phosphorus diet, this person has a lower phosphorus diet. And then if you add on to that saying, okay, well, they're consuming the same amount, then the next thing would say, oh, well, this person absorbed a lot more than this person. But they actually had very similar phosphorus absorption, and it was in their phosphorus balance is where that difference was. So the person with a very high urine phosphorus was not consuming anymore or absorbing anymore. They just weren't retaining it. In fact, they were losing a little bit more phosphorus every day. So some association studies have tried to relate urine phosphorus to things like CKD risk. This particular study, they looked at, they hypothesized that a higher urine phosphorus would be reflective of absorption, so it should be related to a higher risk of CKD, or it's reflective of a higher intake, but they found this conflicting result where they had higher urine phosphorus related to lower risk of cardiovascular disease in these kidney disease patients, and that was a little bit of a conundrum, but this is explainable by this type of scenario that would be happening. So I think I should leave some time for questions. So I think I'm just going to go to maybe to the end and allow for some questions. What do you think? Okay. All right. Maybe I will. Actually, I do want to show you. So our rat study where we had this higher fractional phosphorus absorption in the CKD rats compared to the normal rats, we've seen the same trend now in people with CKD. It was not significantly different. The CKD folks had very similar fractional phosphorus absorption compared to healthy matched controls. So that is somewhere where we've seen that. And we've also seen that this was despite the fact that the CKD patients had lower 125D. And so it just was not holding up that the 125D was related to their fractional absorption. So corroborating what we found in the rats. So let me just, I forgot that I don't have to click through all of these things. So I'll just show you my overall conclusions here. Much of our knowledge is phosphorus absorption is based on in vitro assessments. They may not translate fully in vivo. We have to be mindful of how we use serum and urine phosphorus measurements. Even though they're convenient, they might not be reflecting what we think they are. And these phosphorus and calcium metabolic balance studies are really useful and kind of uniquely useful in revealing this underlying physiology that would otherwise be obscured. All right, so I'll just end on my little acknowledgement slide, and I don't leave that much time for questions, sorry, but happy to take any questions.